So today I have a case. This is a female patient, 31 years of age, presented to my OPD with complaints of chronic right-sided nasal obstruction, time duration being around roughly 2 years, gradually progressive, not sudden in onset. Remember, the chief complaint was severe nasal obstruction, right-sided anosmia. The patient had severe heaviness in the right frontal and the temporal region, headache as well. However, there was no history of any epistaxis whatsoever. Always remember that. You should ask for any patient having a complaint of right sided nasal obstruction, nasal discharge, anosmia. One of the history points should also be the presence of epistaxis, if at all, yes or no. So you got to ask the patient that as well. So the chief complaints of this patient is that severe nasal obstruction and nasal discharge, not foul smelling though, loss of sensation of smell, which is whether it's complete anosmia or whether it's just hyposmia. And what about the left side? So this patient presented to complete right side nasal obstruction, but the left was already, it was perfectly fine. So the patient could smell from the left side normally, but the sensation overall was depleted. So these were the main complaints, nothing major as such. So as a routine thing, I did the endoscopy of the patient, and I saw uh, in the findings I could see on the right side nasal cavity, it was completely full of soft, white, shiny, glistening surface polyps all over, filling up the patient's right nasal cavity. So as you can see, I'm just trying to move around the patient's CT scan, so just that while I'm explaining the history as well, you can actually just go through the patient's images as well, which I'll be explaining in much detail later on. So as a routine after the endoscopy, there are certain cases that should come into your mind as a differential diagnosis. So this patient is a female patient, right? 31 years, not too old, not too young. She's in middle age category. So what can you think of this could be exactly? So the first thing that comes in your mind should be, it could be a case of right side severe polyposis. It could be right sided AC polyp. It could be right sided chronic polyposis basically, because the left side she had no complaints, and on the endoscopy as well the left side turned out to be completely normal with just a little bit of inferior turbinate hypertrophy and nothing much of significance. So on the right side, from the complete anterior nasal cavity to the complete posterior choana, was full of that polypoidal material. Now, why I'm able to say this, because when I checked the patient's left nasal cavity, I could see that the mass is trying to bulge out from the right choana into the left choana, but not completely filling up the left choana, which you'll be able to see on the patient's CT scan. So the patient came to me first time, and I started the patient on steroidal therapy. And considering that there is no invasive fungal characteristics, so I started the patient on steroid, because considering it could be a AC polyp or it could be allergic fungal rhinosinusitis AFRS as well. So the second differential diagnosis which comes to your mind should be AFRS, because this is a case of unilateral polyposis. So AFRS, according to the Bent-Coons criteria, it says that it is unilateral most of the times. So not always, but most of the times it is unilateral. So the first diagnosis should be right side AC polyp, right side polyposis severe. Second, it could be your AFRS. The third differential diagnosis always that should be in your mind is that it could be a benign tumor which is blocking up the maxillary or the ethmoid region, which is quite common to happen in young middle age as well, and that can give rise to secondary polyposis that can appear in the nasal cavity anteriorly as a a polyp. So always have that in your mind. Do not just think that it could be just polyposis. So the next step, as we all know, is a CT scan, which we have to perform. Without CT scan, you can never think of going for the surgery. So the patient completed her steroidal nasal spray and the xylometazoline nasal spray therapy, and few medications for the runny nose and the discharge, and antibiotics as well. considering it could be an infected AC polyp as well. So after 15 days, the patient came back to me, but I did the repeat endoscopy, and there were no changes at all. The polyp size was still the same, so definitely, that was definitely not allergic. Had it been some kind of an allergic polyp, there would have been a little bit of improvement, but the patient, to my surprise, did not have any improvement of any sort. So this gave me a strong suspicion that it is definitely not allergic fungal rhinosinusitis. Also, it is definitely not any allergic polyposis. So it could be either AC polyp, which is basically mostly infectious. It could be also a benign tumor, which is posing anteriorly as a polyp in the anterior nasal part. So now I'm going to show you the CT scan. So I did the patient's plain and contrast CT scan in the first instance, and this what you can see right now is the plain scan right now, what I'm showing you right now. So I'm gonna go through the patient's plain scan. So I'll go from the very anterior part. I'm gonna use this FESS elevator as an indicator for you guys. So if I just focus on the screen right now, you'll be able to see that this is a particular section which is seen in coronal scan. This is a coronal scan around roughly 0.5 mm thickness, and as we're going from the very front part to the very behind part, that is from anterior to posterior, uh, cut by cut. So the first thing, now see, I've done a lot of CT scan videos. I'm just going to go in very short over here just not to waste any time. I'll just cover up the most important points which are relevant in this case in relation to this case. Okay, so as you go from the most anterior to the most posterior part, you can see that this is a frontal skin. That's the frontal nasal process of the maxilla, and that's the nasal septum. We see the frontal sinus coming in the picture right now on the right side. That's the frontal bone, and you can see the actual long frontal process of the maxilla right here with the perpendicular plate of the ethmoids in the picture. And in the very most anterior aspect of the coronal scan, you can see some soft tissue shadow appearing, which is iso intense to the soft tissue shadow elsewhere as well. And you can see this is a midline nasal septal. This is a cartilage over the septum and the mucoperichondrium over it, and you can see it is in close relation. The nasal mass which is appearing right now is in close relation to the mucoperichondrium of the nasal septum. So as we keep on going behind, you can see that the mass becomes bigger and bigger, and you can see at the same time the frontal sinus on the right side is having a septum within the sinus, and this could be the intra sinus septum, and this what you can see over here is the inter sinus septum, because this is attached in the midline over here, and this is intra sinus septum. So as we keep on going behind, you can see a huge pneumatization of the frontal sinus right there, and you can see a few intra sinus septations happening right here, and this is a midline septation, that is a right, and this is a left. You can see that's the frontonasal process of the maxilla, and you can see the huge soft tissue shadow which you can see in the right nasal cavity. So you can imagine it's from the very anterior part of the right side nasal cavity and going right up to the choana and crossing the midline and entering the left side as well. So you can see the left side, this is the inferior turbinate, but on the right side the inferior turbinate is non distinguishable from the nasal mass, which you can see right now over here. So as we go behind, you can see the nasal mass, and you can see the maxillary sinus coming in the picture right now, and you can see the maxillary sinus is full of opacification right here, but the left side is completely normal. As we go behind, you can see the maxillary sinus is quite elongated as compared to the left maxilla. So there's one more thing I noticed on this patient's CT scan, is that the size of the maxillary sinus was very huge. It was, as compared to the left one, the right maxillary sinus from the very start to the very end is almost 1.5 times or as double as that on the left side. So you can see huge pneumatization. Now as you can see, we can see that the patient is having a maxillary sinus picture over here, and this is quite a huge sinus. So as I keep on saying in all my lectures, if at all you see a structure which is similar to the frontal sinus along with the maxillary sinus in the same picture, that is definitely not frontal sinus. Always remember that. This is definitely not frontal sinus, but this is basically supraorbital cell. You can see this is the orbit over here, and it is above that, and hence the name is supra, which is above, and this is the supraorbital cell. You can see the huge pneumatization of both sided supraorbital cell right here. You can see the ethmoidal cell structure coming into the picture right now. You can see the cell system in the anterior ethmoids. You can see that the soft tissue present over here in the right side, and you can actually see, if you see very carefully over here, you can see a faint white structure over here. That's the inferior turbinate bone basically, as compared to the left side structure. You can see that's the inferior turbinate bone, but you cannot differentiate the inferior turbinate separately from the mass, which you can see over here. But you can definitely see that there is an inferior turbinate bone right here. What you can see over here is some kind of neo-osteogenesis happening in the floor of the orbit, or you can say the roof of the maxillary sinus right here. You can see the middle turbinate on the left side having some kind of concha bullosa on the left side. So as we keep on going behind, just keep an eye. Now this scan is definitely not a tilted scan. This is an erect, straight scan. So whatever we see, the size of the maxillary sinus because of the disease that is having inside it, you can see the size of the left maxilla and the size of the right maxilla. It's almost huge, 1.5 times the left maxillary sinus. You can see, you can clearly see the infraorbital nerve canal over here. You can see that's the infraorbital nerve canal, which is clearly seen over here, carrying the infraorbital vessels and the nerve. This is the soft tissue shadow. That's the concha bullosa. That's the inferior turbinate. So you can see somewhat of soft tissue collection in the left maxillary sinus, but that is definitely not that significant as such as compared to the right one. So as we keep on going behind, you can still see the huge supraorbital pneumatization happening over here. So definitely we can, during the surgery, we are definitely going to encounter the supraorbital recess, the supraorbital cell, and I'm definitely going to show you the supraorbital cell as well behind the frontal sinus. So as you can see, the frontal sinus comes anterior and the supraorbital cell comes posterior, and as a default rule, the frontal sinus is anterior, the supraorbital cell is posterior, and once the supraorbital cell gets, the posterior wall appears, behind that you'll see the anterior ethmoidal artery as a rule. So I'm going to show you the anterior ethmoidal artery as we come across that in the next scan. So as you can see, as we keep on going behind, that's the crista galli, that's the skull base, that's the olfactory fossa over here, and you can see, keep a close attention on this particular scan over here. What you can see over here is that this is the meatus, that's the middle meatus and the maxillary sinus opening over here. You can see the left maxilla, this is the osteomeatal complex on the left side, and what you can see on the right side, there's a huge widening you can see over here, and you can see some bright white bony shadow on the floor of the orbit. So that could be a feature of infection, edema, but this is a plain scan, so you should not be seeing any blood vessel on the plain scan. So this could be a neo-osteogenesis happening on the floor of the orbit because of the disease pressure below. You can see somewhat of soft tissue collection happening over here, but that is really not significant as such to this case. It could be some mucosal hypertrophy, but nothing else as such. You can see the size of the sinus is really huge as compared to the left one, and this soft tissue shadow in the maxillary sinus is in continuation with the soft tissue in the nasal cavity, giving an appearance that it could be a single mass or it could be some kind of secretions along with the mass, but we are definitely not able to see any alternate shadow over here. So so far, if you know the basics of CT scan, Had this case been a case of a AFRS, you would have been able to see a lot of dense white hyper bright shadow over here, suggesting the double density sign of typical of AFRS on a plain scan as well. So you cannot see, this is a uniform soft tissue shadow having a huge opening in your maxillary sinus right there. So you can see the maxillary sinus is wide in its appearance, and later on we have to see the status of the floor of the orbit as well. So you can see over here, that's a huge maxillary sinus. That's disease is there. You can see the inferior turbinate bone, the uncinate bone right there. You can see the septum over here, and you can see the left side is completely normal. So as we keep on going behind, the sinus becomes more bigger and bigger, and now at this point, if you start comparing the orbital floor of both sides, you can see some bowing happening over here on the right side because of the pressure which is coming from below above. This pressure of the lesion which is seen in the maxillary sinus over here is trying to compress superiorly the floor of the orbit. So you can appreciate very clearly there is some kind of superior bowing of the floor of the orbit. Now as I keep on going behind, you can appreciate that really well, that there is some kind of bowing happening over here. And as I keep on going behind, you can appreciate that there is a huge maxillary sinus, and this as well. Not very significant as such, because if you compare it to the left side, they have a similar structure. But if you look closely, there is a definite minimal bowing of the floor of the orbit happening because of the compression coming from below. So definitely we got to check for the floor of the orbit once we open up the patient internally with the endoscope. We got to see what this exact nature is all about. So you're going to see the anterior ethmoidal artery. You can see the anterior ethmoidal artery right there. This is still the anterior ethmoidal skull base, because we are still having an oblique, you can see the skull base is still oblique over here. It means that we are still in the anterior ethmoidal skull base, but in the posterior part. You can see that this is the Kennedy nipple sign happening over here. That's the medial rectus, and that's the superior oblique muscle right there, at the confluence of which we always see the anterior ethmoidal artery. Now there's one more thing I want to show you. You can see a lot of septations over here. You can see a lot of septations of bone over here, particularly in this region only. We are not able to see it behind. We were able to see it normally over here, as you can see over here. But as we go behind, the soft tissue takes over this place as well. So always be careful once you open up the patient for surgery internally. You can see that's the anterior ethmoidal artery, and the disease is exactly below that. And you can see this is the termination of the supraorbital cell. So as I was saying, if you remember, that posterior to the supraorbital cell, the moment the supraorbital cell ends, you will see the anterior ethmoidal artery beginning over here. You can see the anterior ethmoidal artery is just running at the floor of the posterior wall of the supraorbital cell, and the disease is completely below the anterior ethmoidal artery. If you look closely at this picture, you can see the anterior ethmoidal artery running along the skull base, and you can see a lot of collection over here. So once you're opening the patient inside, you have to carefully remove these bony attachments and keeping the anterior ethmoidal artery safe, intact. Okay, so we gotta keep the artery intact. We don't want to injure that artery unnecessarily. So as we keep on going behind, you can start seeing that the entire posterior ethmoids, now the posterior ethmoids have begun, and you can start seeing that in these few last scans, the left-sided nasal cavity is also showing some soft tissue shadow right there. You can appreciate that, right? So only at this scan, see, in this scan it was completely normal, but at this scan, completely filling up the lower half of the left-sided nasal cavity. And as we keep on going behind, you can still see now it's completely filling up with a lot of air bubble shadow, indicating it could be infection happening inside. Okay, so ongoing bacterial or fungal infection, but fungal mostly we rule out because we do not see any double density sign over there. So you can see complete opacification of the right side sinonasal cavity along with the left posterior inferior half of the nasal cavity we can see right there. So this is posterior skull base right now, posterior ethmoidal skull base. You can see that's the posterior ethmoidal cell. The orbit is becoming conical in shape. That's a huge maxillary sinus now, completely filling it up. This is some air bubble shadow indicating some kind of infection happening over here. This is the inferior orbital fissure. You can see that's the same situation. That's the posterior skull base over here. Now this is the lesser wing of sphenoid, and that's the right sphenoid. That's the left sphenoid. This is the orbital apex area. This is the inferior orbital fissure right there. Now you can see the both choana are completely full of soft tissue shadow right here. That's the temporal lobe of the brain. And as we go, this is the right sphenoid. That's the left sphenoid right there, right and the left. But as we keep on going behind, you can actually see that the right sphenoid is completely very small, okay, with a minimal collection happening over here. That's the carotid artery shadow. That's the optic nerve shadow over there. That's the medial pterygoid. That's the lateral pterygoid. That's the Vedian canal. That's the maxillary foramen rotundum over there. So Vedian is median, as I keep saying always. So here in this patient, the left sphenoid is quite dominant. The left sphenoid is quite dominant, and the right sphenoid is just very, very small, as you can see. And this is the common opening of the left sphenoid being so dominant that you cannot appreciate the right sphenoid here at all. And as we keep on going behind, this is one common sphenoid opening, and then which terminates into clivus over here. So this is a basic rough scan, both the anatomy and the disease structure. Now the interesting thing is that we got the contrast CT scan done as well, and now I'm going to show you the contrast scan. This was a plain bony window. Now I'm going to show you the contrast scan, and I'm going to show you some interesting findings that turns the entire picture of this situation, of this case basically. So what you can see right now on the screen is a contrast coronal section of the CT scan. So this is called as CECT, which is contrast enhanced CT scan. This is a coronal scan. So as you can see, we already know the anatomy right here, so we're going to go behind. But then the most interesting thing is that as soon as we reach the particular area of the nasal mass over here. Now this is a contrast scan. How do you identify that this is a contrast scan? See, in some of the scans you can see, you can actually see the hyper intense bright shadow in the blood vessels over here, and that's an indication that this is basically a contrast scan. You can see all the blood vessels in the brain right here. That is basically nothing but the blood vessels with the contrast inside it. So this is basically a contrast shadow, but this is a soft tissue window and not a bony window, because now you can see the bone is not showing any kind of bone marrow over here. It is completely bright white. It is not showing bone marrow or the internal bone structure anywhere. So this becomes basically a soft tissue shadow and not a bony window. Okay, this is a soft tissue window, not a bony window. Always remember that. But this is a contrast scan, that's for sure. So see something interesting I'm going to show you right now. So having a suspicion of a benign tumor in my mind, we had the contrast CT scan done. So what you can see over here now, at this particular point, you can see a lot of hyper intense white dense shadows in the superior half of the CT scan in the maxillary sinus. As we keep on going behind, you can actually appreciate that dense whitish shadow over here, which is nothing but the filling up of the contrast in that area. Now you can see dense white tissue shadow is in the nasal cavity as well, and the superior half of the maxilla, which is the floor of the orbit. So as we keep on going behind, the dense shadows starts increasing in amount. You can see the entire superior half is almost showing contrast uptake. You can actually see the contrast uptake over here, and the rest of the tissue shadow you can see over here. So this could be some kind of secretion, okay, which we'll see in the MRI as well. So this is some kind of secretion, for sure, and this is the contrast uptake which you can see in the tissue over here. And you can see a huge amount of contrast uptake which you can see over here in the maxillary sinus. As we keep on going behind, You can see this is the anterior ethmoidal. This is just near the area of the anterior ethmoidal artery. You can see this is the anterior ethmoidal artery coming over here. That's the Kennedy nipple sign, which you can see clearly over here, and that's the skull base, anterior skull base, and that you can see some kind of flaring up happening over here as well, just below the anterior ethmoidal artery. You can see a lot of contrast uptake is happening over here as well. Nothing over here as much. You can see that's the inferior turbinate on the left side. Nothing over here. This is like a gray soft tissue shadow. And now again, you can see that the bone is flaring up over here. It could be neoosteogenesis or the inflammation or the edema happening over there. So now what I see, that you can see some soft tissue shadow happening in the choana region right now. And you can see now both the choana is showing a lot of soft tissue, which is hyperdense whitish shadow over here. As we keep on going behind, you can see a lot of contrast uptake happening in the choana region on both the sides as well. Now as we keep on going behind, the contrast uptake becomes more and more, and you can see now the entire choana is showing up, the almost more than 70% is showing a contrast uptake inside. So as we keep on going behind, the contrast uptake decreases and then the lesion disappears entirely. So you can see that there is a positive uptake of contrast in the CT scan on the right side. So we had to get the patient's MRI scan done, and that is altogether a very different picture, which is showing, strongly suggesting a presence of a benign tumor inside. But then we have to always confirm that intraoperatively and on the histopath examination as well. So this is just a radiological idea which we're going to have. So now I'm going to shift on to the MRI scan of the patient. This was the contrast enhanced CT scan soft tissue shadow over here. Now what you can see on the screen right now is the presence of a MRI scan, and this is basically a T2 scan. Now definitely we all know how to identify the MRI scans of T1 and T2. I've done a lot of videos on that as well. So I'm going to show you in very rough the presence of different structures seen on the MRI scan for this patient. So as you can see, I'm going to show you with a distance, because if I go too close to the screen, it is all becoming bright. So I'm going to keep it at this distance. So this is from the anterior to the posterior right here, you can see, and you can see this is a T2 scan because you can see the aqueous and the vitreous humor flaring up as bright white, and you can also see some kind of CSF in the ventricular space over here. You don't see the ventricles as such very clearly, but a dense shadow you can see over here, faint shadow over here, that is basically CSF. So this is a T2 scan. So as we know, anything fluid, anything which is a secretion, or which will flare up, or any inflammation will flare up on T2 scan and appear as bright white. So as you can see now, you can see this is a nasal polypoidal mass, which we saw in the CT scan as well. This is appearing as bright white. As we keep on going behind, this is appearing as bright white. But now as see, the moment we go in the maxillary sinus, the nasal part is still appearing as bright white. But then the part inside the maxillary sinus, in the very anterior aspect, you can see it is not flaring up. This is T2 scan, but it is showing some hypodensity over here. Okay, so as we keep on going behind, you can see that this is showing some kind of hypodensity in the sinus area right over here. So all this is secretion which is bright white, or it could be just polyp which is full of inflammation or edema inside. But you can see the structure which is in close relation to the floor of the orbit. That's the floor of the orbit right there, and you can see all that mass, all the lesion which is attached to the floor of the orbit, that is the roof of the sinus over here, is all hyperdense. Okay, this is all hyperdense, and this is all polyp and the secretions right here. As we keep on going behind, you can see a huge area of hyperintensity over here. That is an indication that it could be polyp, or it could be secretion inside. but you can see a definite area of hypodensity over here, specifically on the floor of the orbit and the middle meatal area, which is giving a suspicion for being a tumor. Not exactly a tumor, it could be a tumor or something which is having a dense fibrous or vascular network inside. So you can see this is the maxillary sinus of the patient right there, and you can actually see that this superior half of the maxillary sinus is showing a huge hyperdense material, which is definitely not flaring up. So this is definitely a mass or a lesion inside. That is definitely not a polyp, but something else which is not having any secretion inside. It could be soft tissue or it could be a benign lesion inside. And you can see the origin is happening from here at the area of the middle meatus. As we keep on going behind, you can see a huge dark area in the upper half of the maxillary sinus right there. So as we keep on going behind, you can see the actual hyperdensity over here in the superior half, and all the other structures are nothing but bright white. It could be secretion filling up the maxillary sinus because of the secondary blockage happening inside. And you can see the mucosal hypertrophy over here. That's the mucosal edema that flares up on T2 scan. And you can see this is a hypodense area. You can see collection in the upper ethmoidal region as well. So if we go behind, you can see that's the area of the hypodense material. You can actually see that should be roughly the area of the uncinate bone and the inferior area of the infundibulum. And you can see it is a basic hypodense area over there, and you can see some hyperdense area over here as well. So if you see this scan over here, you can see some fine streaks of hyperdense material coming on from the sinus infundibulum. If I just zoom in on this, I hope you're able to see this. You can actually see some fine streaks of hyperdense material which is coming on. Yeah, I think you should see it right now. You can see some fine streaks. This could indicate that the lesion is having an origin from here. Little bit of hyperdense material over here as well, and this is all secretion. You can see the soft tissue shadow on the opposite side is also having a huge hyperdense material in the coronal region, which we saw on the CT scan. Also, this area was taking up all the contrast on the CECT. Exactly. So whatever we saw on the contrast enhanced CT scan, which was taking up all the contrast, the uptake, all that area on MRI is appearing to be as hypo, suggesting that on T2 scan it could be a mass lesion of some kind. So it's, as we keep on going behind, now the maxillary sinus is showing only the hyperintense secretions, and now this coronal part is completely hypo. This could be a soft tissue lesion completely blocking up the coina on both sides. As you can see, this is also the coina on both sides, which is completely opacified and blocked off with the lesion over there. Now as we keep on going behind, now this is all hypo shadow over here. This is all hypo, and then the mass disappears right there. So we did have a suspicion that it could be a benign tumor. The patient was not given a contrast MRI because of the issues of the contrast being injected. So a decision was taken by the concerned team of the radiologist that the contrast MRI should not be done. So a rough estimate was taken that this could be an inverted papilloma. A rough differential diagnosis was in mind that this could be a case of inverted papilloma. It could be a case of a highly infected AC polyp, or also along with a fibrous polyposis along with high vasculature. So I've seen a lot of cases where it turns out to be a infected AC polyp, but some parts show severe fibrosis in the polyp and some parts show a soft polypoidal tissue. So it gives an appearance that it could be a benign tumor or an inverted papilloma. So we're going to go and do the surgery now, and we're going to show you the intra-op findings, and I'll be showing you the exact anatomy of the entire sinonasal region and the tumor mass as well, considering if at all it is a tumor inside. And we'll send that sample for histopath and confirm whether it's actually a polyp or inverted papilloma or any other benign tumor mass. So this is a surgery I'm going to show you right now. As you can see, that's the white, pale yellowish, smooth, glistening surface polyp entirely occupying the right side nasal cavity. So the exact anatomy of this polyp disease, which we saw on the CT, both on the CT and MRI. So you can see it's all mucoid secretion. You can have a glimpse of the lateral wall inferior turbinate on the screen right now, and it's completely filled up with the polypoidal tissue. So the first differential diagnosis which we come to know of is the right-sided AC polyp with a lot of nasal secretions. And the second thing is it could be an inverted papilloma, because a lot of times the inverted papilloma or any benign tumor mostly presents with the AC polyp, and it's an accidental finding. We do not know it, and when we open up the patient inside, we always see it's a formed papillomatous tissue inside, and then we send for the histopath, and it comes positive as inverted papilloma. It could be AFRS, but then we saw the scans, it was not suggestive of any AFRS inside. So what I'm going to do right now is I'm going to instead of infiltrating, I'm just going to do a surface anesthesia over here, decongestion basically. So I use Marisol soaked in normal saline mixed with 2 ampules of adrenaline. I use I use roughly 50-60 ml of normal saline in 2 ampules of adrenaline, and I keep the heart rate of the patient. I ask the anesthetist to keep it at around 60-65 to give me a good visual field. So what I'm going to do in this video is I'm going to show you only the important clips of the important surgery steps, so that you come to know of it very easily. So I'm going to perform, depending on the situation I find inside, I'm going to perform endoscopic modified Denkers. So as you can see, I'm just trying to decongest the area, and I'm trying to go behind the polyp. You can actually appreciate a huge spur on the patient's right side. That's the inferior turbinate, you can see right there. So the inferior turbinate is kind of pinkish red with blood vessels all over it, and you can see the sticky mucus secretion inside. So I'm just going to start debriding the polyp. My main aim first is to clear up the inferior half of the nasal floor, that's the nasal cavity, so as to, all the secretions are going to go inside and not cause a coronal banking effect. So I'm going to take away the remaining polyp along with the secretions with the debrider inside. So what I'm using right now is a 12 rad. It's a 12 rad. So I'm going from below. See my direction of the debrider? The blade is in my view, and I'm going from below above and not from superior below. It's always easy to go from below above, so at the same time you can suck out all the blood that is coming in your field. If you go from above below, uh, it's not you can do that, but it's not gonna, effectively suck away all the blood. So you're gonna go from below above and let the blood have a good flow towards the choana. So as you can see, I have opened up the middle meatal area. You can see the middle turbinate in the superior half of the field right now. And what you can see, my debrider is between the lateral wall and the uncinate process. That's the polypoidal mass in the inferior half. That's the spur you can see. That's the tissue which is coming from the maxillary sinus from lateral to medial. So basically now I'm in the sphenoethmoidal recess. Now you cannot call this as a sphenoethmoidal recess because this is not middle turbinate in the lower half. I'm actually in the posterior region right now, just trying to take away all the polyps and expose the choana right there. So that's the uncinate process which has been completely medialized. Some people might think that this is a middle turbinate and that is the axilla up there, but that's not the case. you can see a huge spur, and below which you can see again a polypoidal tissue, which I'm going to remove so as to avoid the coronal banking effect. So the first aim is not to hurry, is not to rush. You always make sure you remove all the polyp and make sure that the corona is free, so that the anatomy is much more clear to you and the landmarks are right in front of you. The corona acts as a huge landmark for sphenoid sinus and the skull base anatomy. Okay, so you can see, you can appreciate the amount of bleeding I'm having right now. So what type of bleeding is this? Is basically a capillary ooze from the polyp. You can see a lot of blood vessels on the surface of the polyp right now. So far this looks to be as a polyp, and not an invoided papilloma so far, or any benign tumor as such. As we saw on the scan, the main concern, the main area of concern was in the middle meatus, the floor of the orbit, and the anterior ethmoidal region, right? So this is all polyp, which we can see with minimal capillary ooze, which shouldn't be a problem in your initial phase of surgery. So as you can see, we're going slowly, going behind and trying to open up the corona right there. You make sure the suction is not blocked. If it is blocked, you have to make sure you open up the blade of the debrider and clear that area. So I'm showing you all the important steps in the surgery, and I'm gonna show only those steps which are really important for you to understand. So now the corona is free as compared. We're not going to have any collection here. So the inferior half looks to be okay. Just I'm going to suction that out. You can see the corona right there, and you can appreciate a huge mass there as well. So we saw on the CT scan, both the coronas are like completely full of a mass. That is also a tissue behind. That's the polypoidal mass behind. So anteriorly the mass was soft and polypoidal. As we are going behind, it is becoming more fibrous and firm. So as I said, the patient was having this issue since 2 years and gradually progressive. So over a long period of time, the soft polypoidal tissue tends to become more fibrous and becomes more firm. You can see I'm using net cell for decongestion in between. I'm using a 0-degree endoscope right now. That's my straight Blakesley. So that's the uncinate process. It's giving a false impression as if it's a middle turbinate, but if you look closely, the middle turbinate is in the superior half, pushed above and medially by the mass in the maxillary sinus. So I'm going to take away the remaining polypoidal mass in the lower half. Make sure I completely free up the lower half or the area below the spur. So I'm not going to operate on the spur right now as such, because that's not bothering me at all. Later on I might just do a spirectomy, a minimal spirectomy, but right now I'm not going to bother about it. That's the mass which we saw in the CT scan and the MRI, right? Which was taking up on the contrast, and you can see it's all formed. The debrider is also not able to properly suck it up. So now I've opened up that area in the right corona right now. You can see it's formed and polypoidal at the same time. And that's the attached mass which is coming from the maxillary sinus. That's the uncinate process basically. So the uncinate process is pushed inside, that is the towards the medial aspect, towards the septum, and that is basically a outward uncinate. So basically it is basically pushed medially, to be honest. So it's giving a false appearance as that could be a middle turbinate. You can see some sticky mucoid secretion was present in that polypoidal mass. It looks as it is having some kind of attachment on the posterior aspect of the, you can see that's a small attachment on the posterior aspect of the middle, the inferior turbinate. That's the inferior turbinate on the lateral aspect, and you can see a small attachment there to the turbinate with the mass. That's the uncinate process. You can see a huge mass is still there behind, which is going posteriorly. That's the middle turbinate above there, you can see, and that's the uncinate process pushed medially because of the huge mass inside the maxillary sinus. That's the middle turbinate up there. My suction is touching it right now. That's the middle turbinate, and there you can see the axilla above. And below is the uncinate, medially pushed by the mass. See, if you do not know the anatomy, any junior or inexperienced surgeon will consider that as middle turbinate. That's the middle turbinate which I'm touching right now, and that's the above upper deviation, high DNS on this patient. So this is the reason why you need to clear the polyp first and to identify all the landmarks as much as possible. Now you can see that's the axilla over there. That's the proper axilla, and same structure you can see below, but that is the uncinate below and the middle turbinate above. So see how some junior may easily get convinced that this is not the uncinate but the middle turbinate. So I'm just going to give a wash in between. You can use warm saline, Ringer's lactate. I always prefer to use Ringer's lactate and keep on washing in between to take away all the blood clots. This you should make a practice in your routine surgeries. So far, if you can observe, I'm not even touching the inferior turbinate. I'm not even touching the spur. I'm just concerned on removing the polyps as much as I can and to understand the patient's anatomy as much as I can. Because the first anatomy distortion I could see is that the middle turbinate is pushed up so high and the uncinate process is pushed medially, giving an appearance as that it itself is a middle turbinate. So we got that cleared out. And now having that in mind, I'm going to take away the uncinate as well so that I can easily remove the mass behind that. That's the uncinate which I'm removing right now. That's the proper uncinate vertical process. And I'm actually in the infundibulum right now. You can see the foam mass over there, pale yellowish foam mass. So the blade I'm using right now is actually a rad 12 degree. I normally don't use 0 rad. I prefer to use a 12 rad. It gives me a little more edge. So either you can use a debrider or you can just use a turbinectomy Caesar now at this stage and remove the uncinate and then take a rad 40 or a rad 60 debrider blade and go in the middle meatus infundibulum and take away the entire mass. So at this area, I'm so doubtful that this could be having an attachment to the inferior turbinate. So I'm going to just take away all that mass from behind. You can see it's still going superiorly high. So you just got to debride that and make sure the entire lateral wall is free of the mass lesion. That's the part of the polyp I'm taking out right now. See, even if the spur is right there, I'm able to, manipulate my instruments along with the endoscope very easily. So now you can see the choana is almost free, and I can see the adenoids of the patient. Barely a small adenoid is present there. And you can see a white mass, huge mass is still left there, and that is trying to go on the left side nasal cavity. That's a huge mass you can see, which we'll take out later on, not now. So I'll have to do a posterior septectomy of this patient. So once I do a posterior septectomy, I eliminate the chance of any attachments to the mass. Although this mass so far is looking like a polyp, a firm fibrous polyp, but the CT scan and the MRI are giving us huge indications that it could be something else as well. You can see that's a huge mass behind, completely blocking the choana, and that was the attachment site which I removed. The mass is still there in the superior half and the middle part of the middle meatus. That's the rad 12 blade. So as much as I can remove it on the right choana, I'm going to remove that. Whatever is left in the left choana, I'm going to take it once I do a posterior septectomy after I have removed the entire mass on the right side maxilla. So now the spur is kind of blocking my view, but still I'll wait for some time before I remove that spur, because the only reason is that I do not want any extra capillary bleed happening from the septum. So now I'm inside the maxillary sinus. You can see, I can actually see the posterior wall of the sinus over here. And as I'm trying to debride the mass away, there is more evidence that I'm actually in the sinus inside. And that's the posterior wall. Now I'm trying to remove the uncinate process. It looks very firm. So basically, I'm going to have to take my straight Blakesley, grab hold of it, and twist it around and just take it off. So this is my patient's uncinate process I just took away. Okay. So now actually I'm taking off the superior half of the uncinate. So what I removed just now was the vertical process of the uncinate, and now I'm actually in the sinus area. Little bit of fogging happens in between. You got to make sure you have salve on. So you can see that's the posterior wall. Let me just focus and show it to you. That's the posterior wall of the sinus. It's still full of that suspicious mass inside. And for us to have a full access inside, so what I'm going to do right now is I'm going to go for a modified endoscopic Denkers procedure. So I'm going to take away the entire lateral wall outside. And later on, once I do that, I'll do the sporectomy. So you can see it's a huge mass completely till the level of the floor of the orbit, and I can hardly see anything inside apart from that the lesion inside. So I'm gonna go for the Denkers procedure right now. But before that, let me just shave a little bit of mass inside, have a better judgment in the level of floor of the orbit. So that's my rad 40 right now. So that's my rad 40, trying to debride as much as possible from the medial approach. But if I'm not able to do that, I'll go with the modified endoscopic Dankers. So if at all you have any suspicion of this lesion to be of a tumor, uh, you always make sure you do a modified endoscopic Dankers. But before that, do a pre-lacrimal approach. Keep the lateral wall flap along with the inferior turbinate intact, which you can later on suture it up. Just do a pre-lacrimal approach. Have a head-on approach from the opening you make. You can see that's a clear view right now after having deburied the upper part. That's the choana which is free right now. Only the part on the left side is left, which I'll take at the last. So much of the right side nasal cavity is now free. If you remember, the patient's chief complaint was nasal obstruction. That's the bulla behind above and the ground lamella along with that. But the middle turbinate is pushed so high up in this situation right now, we'll have to actually see for the ground lamella if at all it is present or not. So in this, normally the middle turbinate should have been at this level right now, but this area is completely absent of it because the middle turbinate is completely pushed up and medially, which is not in all cases. So right now, just a little bit of wash and then suction it off, clear the field. That's the middle turbinate above there. So the middle turbinate is actually at the level of the lamina papyracea. Usually the lower half of the middle turbinate should be at the level of the maxillary sinus, but it's not in this case. That's the mass on the left side. That's the lateral wall, inferior turbinate. That's the middle turbinate right there. And that's the high DNS above. You can see the middle turbinate is actually compressed between the high level DNS and the lateral wall. So I'm pretty much convinced right now that I should go for a modified endoscopic Denkers. So now listen very carefully. The first step for Denkers procedure is take your coblation, or you can take your cautery, whatever instrument you have. What you can see right now, I'm trying to coblate the mucosa on the lateral nasal wall 1 centimeter below the lower level of the middle turbinate. So in this case, is actually 1 centimeter below the floor of the orbit. Now the maxillary sinus is completely opened up, right? So in this case, I'll take the reference of the floor of the orbit, which I can directly see from the sinus from here. You can see that's the posterior wall of the maxilla, and you can actually see the floor of the orbit. So 1 centimeter below that, and you can see you can coblate the entire lateral nasal wall, including the inferior turbinate, because you're going to take it away at the same time. The reason behind this is because there's a huge capillary blood supply on the lateral nasal wall. So if you directly go and take a blade and take an incision, you can see how easily my coblation machine is trying to remove that mucosa. So now I'm using the ablation mode. Earlier I was using the coagulation mode, and this is the ablation mode right now. So basically this is cutting all the mucosa right now. You can see not a single drop of blood right now. That's the use of the coblation in the surgery of Denkers. Not a single drop of blood. So if you're using a blade, 15 number blade or 11 number blade, and trying to make an incision for the lateral nasal wall, you're gonna have the entire nose with blood all the time. So you can see after using the coblation, that too very fast, not a single drop of blood right now. So I'm going to take away that mucosa 1 centimeter below the level of the floor of the orbit till the level of the floor of the nose on the lateral nasal wall. So I'm going to take away all the mucosa as you can see right now. And then I'm going to go and find the junction of the medial and the anterior lateral wall of the maxilla, which I'll show you how to do that. You can see the inferior turbinate part I have kept intact a little bit, which I'll take out later on. So that's my Freer's elevator. Now I'm trying to find the junction of the anterior lateral and the medial maxillary wall. So that's the junction I can feel right there. You can see some mucosa is still intact there. So that's the junction of the maxillary walls. That's basically the piriform aperture area. I'm going to take my coblation now, and I'm going to burn that entire area, making sure that the tip of the coblation is under view. So now I'm going to use the coagulation mode, not the ablation. Okay. So I'm going to coagulate. See, the direction of the coblation is towards the septum and not away from it. Slowly, very slowly, be careful. You try to coagulate that so that there is no bleeding happening, which keeps your field clear. You can see how the coblation is having a constant water source, water irrigation, suction at the same time. You can see the direction of the titanium blade is towards the septum, and I'm trying to open up an area. Now what I'm doing is I'm using the ablation mode right now, the cutting mode basically. So you can see that's the how easily the tissue is being cut off right now. So you're going to have a constant suction clearance in your coblation. You can actually see I have exposed the anterior lateral wall of the maxilla right now very, very easily. Not a single drop of blood I can see right now. So make sure you just suction it out, everything inside. Now, what are the steps of this modified endoscopic Dankers? First, we already have done 1 centimeter below the floor of the orbit. Now I'm going to take my FESS and I'm going to elevate the soft tissue from the anterior lateral wall of the maxilla, and what I will see right now, the first structure, the neural structure which I'll be seeing right now, is the anterior superior alveolar nerve. I'll show you that right away. Can you see something right now? I'll show you. You can see a firm cord-like structure coming out from the bony foramen. That is nothing but the anterior superior alveolar nerve. I'll show you much more clearly. There are 2, 3, 4 branches of the anterior superior alveolar nerve that enter into the foramen and supply the upper incisor teeth of the patient. So you can use a suction FESS here, so you can have a better effect. So the first step we have completed. Second step is that I'm going to just expose the anterior lateral wall. So that's my FESS suction, which can suction out at the same time. Now I'm going to show you the anterior superior alveolar nerve. You can actually see a small nerve right there. You can see a nerve with a small foramen of the bone. That's one of the branches of the anterior superior alveolar nerve right there. And one you can see below as well. So let me focus. Yeah, can you see that foramen up there? That's the anterior superior alveolar nerve right there. Okay, so as we elevate, and there's one more foramen below right there. I'll show you in a moment. Can you see that? You can see a foramen right there. That's a huge foramen. Trust me, that is not the infraorbital nerve. You can see one more foramen right there above. So all these are nothing but the anterior superior alveolar nerve, which is supplying the incisor teeth up there. You can see that's the anterior superior alveolar nerve branches. Then behind that will be middle superior alveolar nerve, then the posterior superior alveolar nerve, as we keep on going behind. So I'm trying to keep the lower foramen intact so as to not have any issue. You can see one more foramen right there. So the lateral limit of the anterior lateral wall should be the level of the infraorbital nerve, which I'll show you in some time. So this is basically the anterior lateral wall of the maxilla, which we have to drill out in case of modified endoscopic Denkers. So first step done. Second step we just finished, that is the exposure of the anterior lateral wall after finding the pyriform aperture. Now the third step will be to take a drill, take a diamond burr. I'm just going to keep a patty soaked in the solution in the plane of dissection right there, just to avoid any capillary ooze or any injury to the nerve. So once I open up the maxilla, I'm going to have a head-on view of the tumor, so-called tumor or suspected tumor, or the mass lesion inside. So very carefully, you're gonna dissect using a neuropathy. So whenever there is a surgery where you require head-on exposure to the maxillary sinus in case of a tumor, a benign tumor, inverted papilloma, recurrent AC polyps, or huge AFRS, you can see all the nerves coming on the foramen. So you can always use a modified Dankers procedure. So that's the mucosa on the lateral nasal wall. Everything is gonna go out. You can use a debrider or just pull it out. Just make sure that you do not injure any skull-based structure above. So next step is the drilling pad. So now I'm going to take my diamond drill. You can see that's my coarse diamond. It's not a plain diamond, it's a coarse, rough diamond actually. So I'm going to keep it on the anterior lateral wall, keep my endoscope. So I'm holding the endoscope in my left hand and the drill in my right hand, and the assistant is giving me irrigation, and the second assistant is holding the suction for my field. So you can really appreciate the coarse diamond surface over here on the burp. That's my second assistant holding the suction, trying to give me a clear field. So this is basically right now a right-sided four-handed technique for me right now. So you can see, take a diamond drill. Do not take a cutting drill if you are a beginner. If you are just learning the surgery, do not use a cutting drill. Have a good motion on your drilling motion. You can see a small dent which we have created on the anterior lateral wall. Once we open this up, we are directly in the sinus head on. See how my endoscope is so stable along with the drill being so stable. So you got to learn the coordination between your left and the right hand. So my assistant will give this the irrigation and the suction right now. So you can see we are almost through. Let my assistant just suction it out, and then I'll be able to see what is there inside. So you can see we are almost there. That's the mucosa from inside, and that's it. We are through the maxillary sinus. So now I'm just going to irrigate the area and clear it off. Let me just focus it properly. Can you see that? That's a huge opening in the sinus. Just 2-minute drilling and we are right there inside. So we are miles away from the infraorbital nerve, which I'll show you in some time. I'll show you the entire course of the infraorbital nerve from internal aspect. So we are miles away from the nerve right now. You can see the anterior superior alveolar nerve just below the opening which we have made, which is intact for me right now. That's the pre-lacrimal approach basically. So what we have done so far, so imagine the lateral nasal wall is having an intact inferior turbinate and the mucosa, and you have just elevated the anterior lateral wall of the maxilla, the mucosa, and you just drill the area where I'm drilling right now. This becomes the pre-lacrimal approach because we are anterior to the lacrimal sac right now. So if you just want to examine the sinus from within, you can use this prelacrimal approach and then suture the mucosa which you have elevated from the lateral nasal wall. It is this easy, trust me. Anyone can do this if you know the anatomy. How clearly you can see the nerve below, that's the anterior superior alveolar nerve, which we have kept intact. So we're going to just drill a little bit more superiorly to have more exposure inside, because I want to see for sure what type of lesion we are dealing with here right now. So make sure you do not drill on the nerve, otherwise the patient is going to land up in some kind of loss of sensation over the canine and the incisor teeth above there. So you got to make sure your assistant cleans up the endoscope tip. You just defog that area. So all these basic things you have to learn, and you're going to learn only when you operate, otherwise no. So you have to keep on operating, learn from your own mistakes, improve your skills. So you can see one of the assistants is holding a Freyr's elevator and is giving me retraction so that I can just keep my endoscope properly in the area. You can see I'm holding the endoscope right now, and my assistant is holding the flap and giving me a proper view for my endoscope. Now I'm using the drill. I'm going to drill the area and make the opening bigger. So the next step is to expose the lacrimal sac area because I do not want to damage it. I want to expose the entire lacrimal sac from the floor of the orbit to the floor of the nose. So a little bit of drilling here and there. Make sure that while you are drilling, the irrigation is on and the suction is on as well. So here comes off the superior part of the medial wall. That's the basically lateral nasal wall. That's the inferior turbinate part, which we are going to take away little later on once I have exposed the sinus completely. So you can see my assistant is holding the frares for my endoscope. You can actually see that's a huge bloody mass inside. That's a huge bloody mass we can see right now. So this is a bony spur that we have to remove that segment to have more exposure inside. And you can see how the endoscope and the drill are so in well coordination right now. And always make sure that the tip of your endoscope is miles away from the burr, otherwise your endoscope is going to be damaged. All this you have to be careful of. So we have a bigger opening. You can see the mucosa of the sinus from within, and in some time we'll be able to see the mass as well. So the exposure is the key over here. So you gotta have a good exposure, take away all the bony overhangs, and have a head-on view of the sinus inside. So you can see I'm still using a diamond burr. I always use a diamond burr inside the nose. I hardly use any cutting burr inside because that is kind of dangerous. So the burr which you should be using is the diamond burr properly. So you can see now we have huge exposure inside, and you can see it's all bloody red inside. It's a huge reddish pinkish mass is what I can see right now. So the only thing I have left I'm left to remove is the lacrimal sac. Once I remove the lacrimal sac and the lacrimal the duct area, I'll flush the lacrimal sac on the floor of the orbit level. So you can see it's a lot of polypoidal. Now this is a secretion which we saw on the MRI scan. You can see that's a huge mass, a lot of bloody patches on the lesion right there, along with secretions and greenish yellow collection. Now that is the actual mass that I'm really concerned about. It's that's all the secretion below which we saw on the MRI scan as a hyper intense area. Now you can see we have a huge view inside. That's all the polypoidal mucosa. And that is the streak which we saw on the MRI scan, the streak-like hyperdense situation. That was the lesion which we just saw on the MRI scan. So this looks like a formed polyp along with that reddish pinkish mass above in the floor of the orbit area. So let me just drill away more and have a better exposure because I'm really concerned about the nature of the mass which we are dealing with here right now. So the only reason I'm doing all this Denkers and extensive drilling is the reason that I am still suspecting it to be a tumor, a benign tumor, or it could be a combination of both, a tumor and the polyp. So I don't want any attachment left behind. So for superior exposure and head-on movement, I'm doing all that Denkers procedure with minimal damage as much as possible. So you can see the assistant is still holding on to the flap for me to have a better exposure. Now I'm going to take away the lower half of the inferior turbinate and the lateral nasal wall, but I'm going to skip this and I'm going to show you more important structure right there. So that's a huge reddish mass which we saw in the CT and the MRI, taking up all the contrast inside. And I'm going to take away that mass, take it out in one go. I hope I can do that and send that mass for histopath. Now what you can do, if at all possible, you can send that for frozen section. You can get the reports in like within half an hour and be confirmed for sure about the nature of the mass. You can see a lot of bloody hemorrhagic patches, a lot of petechiae on the surface of the polyp and the mass right there. I think that was the area, because of the lot of bloody area inside, that was taking up the contrast as well. You can see that's a huge mass inside. That's a really huge mass inside, and you can see a lot of hemorrhage areas inside. I think that was the area that was taking up all the contrast inside. So the lesion is having active blood flow within. That's for sure. You can actually see a lot of red patches, hemorrhagic patches inside, and on the CT scan, the contrast was being taken up. That means the lesion is having a lot of active blood supply inside. This is definitely not looking like a regular polyp inside, that's for sure. You can see a lot of blood vessels inside and a lot of irregular surface on this lesion. Definitely, it is not just a routine polyp. There has to be something else along with that, which we'll come to know only after histopath. So we can have a suspicion on clinical basis and on radiological basis, but that has to be confirmed always on the basis of histopathology. So I'm going to take a biopsy as a whole of this, but you can see a lot of different pedunculated masses also. You can see a lot of different masses on that lesion. Active ooze taking place right now. Definitely not a regular polyp which we see in our routine cases of AC polyp or AFRS. This could be either a very high level infected AC polyp which has become more, fibrous, formed and having a lot of blood vessels within, or it could be some tumor, that's for sure. So I'll just skip this part. So what you can see right now is I've taken off the inferior turbinate completely, and now I'm gonna cut that inferior turbinate and take it out. So we saw initially that we seeing some kind of attachment on the posterior half of the inferior turbinate, right? Which we removed. Now that's the inferior turbinate which is coming out as a whole. Once it's out, I'm gonna give you a proper view of that. So using my Blakesley to take it out. So that's the inferior turbinate, you can see. So now the lateral wall is completely free and we can drill that out to make sure that any kind of attachment is out. So you can see the corona is completely free right now. The posterior half, you can see that's the area of the attachment which we saw some time back. That I'm going to drill out completely. So now the only thing left here is to remove the bone anterior to the lacrimal sac, expose the lacrimal sac and flush it at the level of the floor of the orbit. So I'm going to directly skip onto that area. So now what you can see me doing here is I'm taking my diamond drill and I'm drilling the bone which is anterior to that nasolacrimal gland, sorry, not the gland, the sac and the duct. So very carefully anterior to that sac level, you should drill all the bone. Now what I'm drilling right now is basically the bone which is the frontal process of the maxilla, the lower part of it, that forms the anterior wall of the lacrimal sac, the bony wall, and the posterior bony wall of the lacrimal sac is formed by the lacrimal bone, right? So the lacrimal bone is very thin and the frontal process of the maxilla is kind of thick. So what you can see is the anterior wall coming out. So you can see the endoscope is very stable in the left hand. Wherever my drill is going, my endoscope is following that. So if you're a beginner, trust me, you have to take your own time. Do not rush and do not give any permanent complication to the patient out there. That's the mucosa, that's the lateral nasal wall mucosa right there. So the mass is still inside the sinus. We haven't taken it off yet. Once I remove the nasolacrimal gland, the duct area, then I'll take the maxillary mass as a whole. So I'm going to show you each and every step of how to carefully preserve the nasolacrimal system and how to flush it off at the floor of the orbit. So just pay attention to whatever bone I'm removing right now, the anterior bone, the medial and the lateral, and the posterior bone as well, to the lacrimal sac. So you can use a Blakesley forceps. Now that's the bone which is, you can see the sac already right now. The sac is in vision right now. So piece by piece, take all the bone out carefully. Now that's my upward bone punch. I'm going to take away the superior bone anterior to the nasolacrimal sac. So you got to take hold of it, twist it, and remove the bone. You can see the sac right there. That's the nasolacrimal sac. Just take away the bone. You can use a drill as well. Nothing to worry about that. I can actually see the superior half of the sac coming in the picture right now. So once all that bone goes out, you will see the sac completely. I'm going to completely expose the sac. I'm going to remove each and every bone surrounding it so as just to give you a complete anatomical knowledge of it. So in my experience, bone punch is way faster than the drill. If at all possible, you can use your bone punch. Little bit of anterior bone is still left. Now make sure that the patient after surgery is going to have a little bit of cheek swelling and a little bit of altered sensation in the tooth, in the canine and the incisor area basically. But that becomes all normal in few weeks. The nerve regrows back and the edema settles off and the inflammation decreases. That's the bone which is in the superior half. It's mostly tough. You can actually see the sac behind that. Once that bone is out, your entire sac is in picture right now. You can see the entire bone coming off with the bone punch. Now you can have a glimpse of the medial sac over there. You can see that's a huge bone that was covering it. I'm going to take it off. That's a huge bone right there, which was encasing the lacrimal sac area completely. I hope you can appreciate that as a huge bone which was covering the sac, and you can see the mass lesion right below it. So with your Blakesley, just try to remove that very carefully. Do not pull it. So I'm going to drill this bone a little bit. So at the moment I start my drilling, my assistant is going to keep pouring on water from above. So I do not have a dry field. You can see it's pouring water in between. and my second assistant will hold a suction in some time and take away, if at all I have a blocked vision. Otherwise, it's all good. So you can see I'm just trying to flush the area of the floor of the orbit by drilling all the irregular bony areas. So I'm going to take away all that bone. So as you can see, the sac is open from anterior aspect completely. Now the posterior bone is still left. You can see the sac is hanging right there, but the bone is still present in the superior and the posterior half. So I'm going to take a ball probe and I'm going to slide along the posterior bone, which is the lacrimal bone basically, and I'm going to take it off. So a huge clearance we have achieved so far. That's a huge mass which you can see completely, almost completely occupying the maxillary sinus right there. You can see that's a very, very huge mass indeed. Now the only structure between me and the mass is the lacrimal sac right now. You can see that's the lacrimal sac and that's the lacrimal duct below. And you can see still a bone which is still left behind. That's the lacrimal bone behind. So if you see the anatomy, the anterior major part is by the frontal process of the maxilla, and the posterior half roughly is by the lacrimal bone. So now what I'm removing is the lacrimal bone from behind. So if you do this step very carefully, you don't have to do a formal DCR for the patient. Otherwise, if you screw this step up, if you screw it up, you'll have to do the formal DCR before the patient is awake and conscious. That's a huge mass you can see. So once I take away the lacrimal sac area, that huge access which I'll be getting, I'll take away that mass in toto. That's the lacrimal bone. You can clearly see that's the thin lacrimal bone behind. How beautifully I can visualize that. I'll just take my ball probe and remove that. Superiorly also you can see I can just use my drill or a bone punch and remove all that bone. I can actually see the floor of orbit as well. So in this situation, the bone punch comes in handy. The drill may sometimes, jump off to the sac and, end up rupturing or lacerating the lacrimal sac indeed. So you can see how easily I can remove that bone superiorly. That's the most superior part of the lacrimal sac, above which you will start seeing the common canaliculus area. So one more bone punch right there. Now you can see how the sac has become loose because all the bone is gone now, and I'm just going to flush it off on the floor of the orbit level. Now how to do that, I'll show you in some time. I think a little bit of bone is still left on the medial aspect. Let me just focus that. Little bit of ooze is happening from the sac area. So that's the sac area. You can see the capillary ooze happening from the sac area. That's the ooze. But that's no issue because we anyways have to remove that area. A thin bone is still left behind. That's the lacrimal bone, and I'm going to remove that with the help of a ball probe. You can see how beautiful the sac is looking. all vascular. It's highly vascular because the patient has a very flary, ready mucosa over here because of all the infection happening. You can see all the blood vessels actually running on the sac area. So that's the bone which is still left behind, the only structure between me and the mass right there. That's the lacrimal bone behind, the only bone left. So theory suggests that the bone which is superior, which I'm removing right now, is kind of hard to remove as compared to the one below. So you can either use a drill or a very powerful punch out there, or you can just drill in the initial half, make it weak, and then you can punch it off. Now you can see that's the area of the floor of the orbit. My suction is at the floor of the orbit right now, and I have exposed the sac up to the level of the floor of the orbit. So anything above, if we go, we're gonna see the common canalicles inside the sac. So I think my superior exposure is good. Now I'm gonna take my ball probe and I'm gonna slide along and remove any kind of bony attachments whatsoever. So the ball probe is blunt, so it's never ever gonna puncture the lacrimal sac area. You can see how easily I'm taking all the bony chips away from it without even causing trauma to the sac area. I can still remove that bit of bone which is still left. You can see that's the bony chip from behind. That's a brilliant exposure. I can still keep on going higher and higher. That's the superior posterior half of the lacrimal covering. So this is purely a capillary ooze which is happening from all over the mucosa and especially the mass lesion here because it is highly vascular, and that is why the uptake was being taken up by the mass. So now I'm going to take the Blakesley and retract the lacrimal sac below, but I'm still not happy with the exposure I have. I need to still go higher up because see, if we do not flush the lacrimal sac at the level of the floor of the orbit, the patient will land up in fibrosis and later on she will have epiphora. So instead of doing it later, you have to do it now carefully. And now it's properly the floor of the orbit you can see right now. So now I'm going to take the drill away the superior half, the superior part, make it smooth. You can see that the diamond burr really comes in handy, and the drill system is also very working in a very brilliant way right now. So whatever system I use, the debrider system, the coblation system, and the drill system which you're seeing right now, I've purchased it all from a dealer. His name I'll give in the description below, and then he gives me brilliant service in terms of in regards to the debrider, coblation, and the drill system. So whatever instruments you can see I'm using right now with the drill, coblation, and the debrider is all from that guy. So this is basically a 3 mm diamond burr. It's a 3 mm diamond burr, and you can see how easily it is smoothing off the bony margins up there. So in skull-based procedures as well, I prefer to use a 2 mm diamond burr. Not coarse diamond as such, but the plain diamond. This is a coarse diamond which I'm using right now. So one final step is to remove the lacrimal sac, and then later on I'll show you the anatomy and the posterior septectomy, and I'll also show you the anterior ethmoidal artery, but I'll show all those structures in very short. The only reason I'm showing you all this in detail here is that you should know the anatomy and the procedure of doing a Denkers and how to properly remove the nasolacrimal duct system and flush it off at the floor of the orbit. Okay, so I'm all set. I can actually see the superior level of the sac area. Now I'm just going to take my Blakesley and retract it and cut it flush. So you can see how freely it is now moving anterior and posteriorly. You can still see a thin film of bone behind. So you can imagine the amount of bony covering the lacrimal sac has in a normal human being. You can still see a huge plate of bone right there, and that I'm going to remove. So this basically is the uncinate bone which I was talking about, along with the posterior part of the bone that covers the lacrimal sac. So that is the combination of uncinate and the posterior lacrimal sac bone, lacrimal bone basically. So when you're doing a formal DCR surgery, you know that we come from posterior to the anterior, and it shows a lot of bony covering which we have to remove in terms of its exposure. So that bone is out right now, and now the lacrimal sac is hanging freely in the sinus cavity. That's the bone along with the uncinate, a part of the uncinate, not the whole one. So now you can see the lacrimal sac is freely hanging, and there's no bony attachment whatsoever inside now. Now this is basically a small chip of bone which is connected posteriorly to the perpendicular plate of the palatine bone. And that's the floor of the orbit. You can actually see the skull base as well. Not clearly, but you can just have an estimate. Okay, so now it's time for me to take my Blakesley, retract the sac below. As you can see, uh, my assistant is holding the sac below and giving a gentle traction below. You can see now it becomes taut. And now I'm going to take my turbinectomy Caesar with the endoscope in my left hand. I'm just going to see whether it is the floor of the orbit level or not. You can see that's the lacrimal sac area. That's the superior part where the common canaliculus opens up inside. And that's the floor of the orbit level. You can see that's the floor of the orbit, below which is the orbit. So my assistant is going to give a traction, and I'm going to take my turbinectomy Caesar, and in one single cut, I'm going to flush it a little below from the floor of the orbit. You can see that? One touch. That's it. The entire nasolacrimal sac is out. And now I'm going to press on the lacrimal area from outside. I'm going to show you that in some time. So all this comes out very easily. If you want, you can still go higher up and flush it off. But make sure it's not hanging in the sinus cavity. Otherwise, it's going to undergo fibrosis. And you can ask the patient to go for lacrimal massages later on. See that? I'm pressing it from outside. You can actually see the movement happening and the drops coming from inside. That's the area where you press it for. And then you can see it from inside. You can see proper movements and drops coming out as well. So this is a proper procedure done. It's a good procedure done. Now moving on to the excision of the sino-nasal mass inside. A little bit of a wash. Now you can see we have a huge exposure, and the mass being so huge, we can deliver it now from the sinonasal cavity. You can see the mass is really, really huge, and it's very red, having a lot of blood. You can see a lot of blood vessels on the surface, a lot of hemorrhagia as well. See that mass lesion was in connection going posteriorly into the choana. So this basically the spread is typical of the AC polyp, but the appearance is either an infected AC polyp, severe infected AC polyp, long-term severe AC polyp which is infected inside, and hence as a result of which it has a lot of blood supply, or it could be something else. So sometimes patients cannot afford the frozen section because in some areas it is very expensive and patient does not agree to it. Sometimes the frozen section is not available nearby to the surgeon, so they do not send it and they have to wait for 2-3 days for the reports to come in. So you can see how huge that mass is. And I'm going to try to remove this bony chip first, and then later on, I'm going to try to remove that entire mass in toto. You can see the mass is somewhat attached below. That is a small bony chip that is left behind, which will smoothen that out. The only reason I'm doing this is because I need to deliver that mask completely outside without rupturing it. So any bony edges or any sharp edges, I'll take care of that. So that's the drilling which I'm doing on the anterior lateral wall of the maxilla. So you can see how good of an exposure we have achieved after using the Denkers procedure inside. So later on, I'm going to drill the nasal floor in connection to the sinus over here. Whatever elevations you can see right now, I'm trying to make it smooth. So once you do that, you make sure you remove. So there are two other ways from where we can take the mask outside. So if you find that it's difficult for the mass to be taken out from the nose, you can cut that in two or three pieces and take it piece by piece. But if you're not a fan of that procedure, what you can do is that you can push away the huge mass into the choana, and you can deliver it from the oral cavity of the patient. But in this case, already we have a huge mass on the left side choana, so we don't have much of a space. Now what you can see, I have removed a plate of bone which was in connection with the nasal floor and the medial maxillary wall. A lot of patients I have come across where we see that it's a polyp and it turns out to be an inverted papilloma. But the inverted papilloma has a typical appearance. It has a papillomatous, finger-like projections, wavy patterns, typical appearance on the MRI scan as well. But whatever scans we just went through, they also typically suggest that it could be a benign tumor. So keeping that one differential diagnosis in mind, you make sure that you do not leave behind any attachments and drill away the bone at the site of attachment. So meanwhile, I'm just going to decongest the opposite side because we'll have to take away the mass from the left side as well. So I'm going to skip this part. So as you can see, I'm trying to, completely expose the area of that sinonasal mass lesion. And you can see it's having a lot of mucosal attachments inside. And now this is my Blakesley, and I'm going to take it out completely outside in one go. Try to make it come in one go. So that's a huge mass you can see. That's now I'm going to take it outside. There you go. That's a huge mass, polypoidal form in the center. You can see a lot of blood vessels on the surface as well, and a lot of yellowish deposit as well. So that is one mass which is out. And there's one more part left to it. So it's coming in piece basically because of the attachment. You can see a lot of mucosal attachments are still there. So once this mass is out, I'm going to show you in very short steps the different anatomy of the anterior skull base, the anterior ethmoidal artery, and various other structures in very, very short. But I'll cover all the important points now that this mass is out, the endoscopic Dankers is understood. Now I'm going to show you the anatomy of all the structures. I'm going to show you the entire course of the infraorbital nerve from the maxillary point of view, and also I'm going to show you the exit of the infraorbital nerve from the canal outside. Now what you can see right now is the posterior wall of the maxillary sinus. That's the floor below. You can see a small retention cyst there with yellow fluid inside, and that's the floor where my suction is right now. And you can see on the anterior lateral inferior part a small retention cyst with a lot of blood supply. You can see a lot of capillary ooze is there. So that is basically the site of attachment of that polyp. Yeah, the place where my forceps is right now is the place of attachment of that polyp right now, which is So what I'm going to do is I'm going to remove that mucosa. I'm going to strip away that mucosa and make sure that the site of attachment of that polyp is gone forever. You can see that that's the posterior wall, that's the sinus mucosa, and I'm going to take it off. Also, considering that this could be a benign tumor partly along with the polyp, until the report comes, we're going to consider this as a tumor. One of the differential diagnoses should be a tumor, and you can remove the mucosa without any complication. That's the floor of the orbit. You can see that's the floor of the orbit above. That's the posterior wall. That's the anterolateral wall, and that's the place where we did the drilling, right? So we can completely see all the walls once we do the Denkers procedure. So now I'm going to show you the infraorbital nerve, then the anterior ethmoidal artery, then the anterior and the posterior skull base, and then the sphenoid sinus as well, and then we'll finish off the surgery. So I'm changing my endoscope to 70-degree, and I'm gonna give you a inferior directed 70-degree endoscope view of the floor of the maxillary sinus. Just let me do a white balance, and here we go. So this is my 70-degree endoscope facing upwards right now, and I'm gonna rotate that. This is my 70-degree endoscope facing upwards. Now I'm turning my scope to the left side. You can see the sinus from inside. Now what I'm going to do is, right, I'm facing my 70-degree endoscope now downwards. Now what you can see is a head-on view of the inferior aspect of the maxillary sinus. I'm going to show you the patient's the molar tooth as well. The premolar, molar, I guess. Let me just focus that. So that's the 70-degree endoscope facing downwards. Okay, so slowly you go there, and now that's the floor of the sinus. So you can use your 70 endoscope facing upwards and downwards. This is facing downwards. What you can see right now is the site of attachment of that polypoidal sinonasal mass where the capillary ooze is coming from. That's a small retention cyst. That's the floor of the sinus which you're seeing right now. That's the most anterolateral part where the sinus is having a retention cyst, smaller one. What I'm touching right now is the floor of the maxillary sinus. You can actually see the impression of the molar and the premolar tooth right there. I'll show you. Wait. That's the premolar. That's the molar, I guess. You can actually see the impressions of the teeth over there. So if you accidentally drill on that area, the patient is going to lose the tooth right away. So you can actually see 1, 2, 3, 4. You can actually see 4 teeth down there below. That's the anterolateral wall inferiorly. So in cases of oroentral fistula or the infections which is because of the dental origin, that is the odontogenic origin of the maxillary pus, you can use your 70-degree endoscope in a downward facing manner and see for any fistula actively oozing pus inside. So I just showed you 4 teeth inside because of the excess pneumatization of the patient's right-sided uh, sinus. Also, the patient was having a lot of sinonasal compression inside in the maxillary sinus. So there is excess pneumatization, and hence you can actually see the impression of the tooth inside. That's the 70-degree facing upwards right now. So I'm going to skip on to the infraorbital nerve right now. So I'm going to take my phrase elevator, suction elevator, and I'm gonna just elevate the mucosa, the soft tissue over there. And what you can see right now, exactly right now, yes, there it is. See, you can see something huge, a huge white structure, a cord-like structure. That's the infraorbital nerve right there. That's the infraorbital nerve. That's the anterolateral wall of the maxilla from outside, and a huge structure. You can see the foramen as well. That's the infraorbital foramen, and that's the infraorbital nerve coming out from the canal. And now I'm going to show you the course of the infraorbital nerve from inside. I'm going to follow the floor of the orbit. So let me just do the suction here real quick. So the infraorbital nerve comes from the floor of the orbit from the pterygopalatine fossa and travels through the inferior orbital fissure and exits again through the floor of the orbit and then the canal, which is 5 mm below the floor of the orbit. So a little bit of decongestion. So now I'm going to remove the packing material from the left side, which I had kept it some time back. Now you can see that I have done a posterior septectomy. I have taken the incision on the posterior septum, and I've cut the nasal, the flap, the mucoperiosteal flap posteriorly from both the sides, and I've also taken the incision in the septum. So this is basically a posterior septectomy, which I'm going to extend inferiorly. You can see a lot of cheesy necrotic pus type secretion on the left nasal cavity, which I'm trying to remove right now with a lot of black granulations here. So this is basically entrapped inspissated mucus secretions. This is basically could be a combination of pus and the entrapped secretions, but this is most likely an inspissated secretion. So you can see the amount of thickness it has. It's very, very cheesy as well. So now going to the left side again, behind you can see the huge mass. Now this looks like a very cheesy, necrotic, whitish, pale, fibrotic mass over here. Now this mass as well was showing on the contrast study a lot of uptake, right? So on both sides of choana, it was showing a lot of uptake. So this could be also having a lot of blood vessels, but we have removed the attachment, so it has become pale as of right now. So I'm just gonna push the middle turbinate to the lateral aspect, have more exposure on the septum. Now, why I'm doing a posterior septectomy? Because having a differential diagnosis of a benign tumor, at least 5% chances of being a benign tumor, or if at all it has any attachments, we should be able to remove the posterior septum. So I'm taking my upwards through cut and I'm going to cut away all the structures over here. So using a through cut makes sure that you do not have any bleeding at all. That's the advantage. You can see that that's the advantage of having a through cut. It just cuts right away without any mucosal bleeding or trauma. So there is no pulling, twisting or anything. You just cut it. That's it. You take the chunk out and then slowly, once the septum is out, I'm gonna take away that posterior nasal mass as well. The patient normally does not have any complications after getting a posterior septectomy done. It's it's completely, I think it's nearly harmless if done correctly. You can see that's a huge posterior coronal part left behind with a lot of blood supply. You can see a lot of blood vessels on the surface of that. So a little bit of tissue is still left in the posterior septum. Once I remove that, I'm going to deliver that as well. So I'm going to skip to the part where I remove that. So now I can see I've done a complete posterior septectomy with the ischaking tube on both sides completely visible in one picture, and the mass is sitting right there. So after having done a proper posterior septectomy, I'm going to deliver that mass outside. You can see that's the posterior septectomy done on the central part. That's the mass right there. You can see the pulsations of the carotid inside. That's a firm, yellowish, pale, fibrous mass with a lot of blood supply over it. So you can see the mass is still extending below in the oral cavity, oropharynx. That's a huge mass in the posterior part aspect. We just have to make sure whether it still is having any attachments whatsoever. You can appreciate the huge size of the mass right there. So after proper exposure, you can now remove that very safely. So I'm just going to take my Blakesley. You can make sure it doesn't get damaged. You can see it's very fragile in certain parts. It's definitely not looking like a polyp. It could be either a very fibrous polyp or an unknown lesion up there. You can see the huge size of it coming outside right now. So that's it. We're going to take this out and send this sample for histopath as soon as possible. You can see that it's very huge right now. So this was a part which we saw on the scan. You can see it's actually really huge. This was a part which was showing a lot of uptake of the contrast. That's it. That's the mass we're going to send for sampling right there. So now the entire Sino Nasal Mass, the so-called mass lesion, has come out. Now we just left with the anterior ethmoidectomy along with the skull base exposure and the exposure of the anterior ethmoidal artery, the frontal sinus I'm going to show you, and the supraorbital cell as well I'm going to show you right away. Now on the CT scan which we saw, right, a huge frontal sinus and a huge supraorbital, and exactly behind that was the anterior ethmoidal artery. So I'm going to show you all the structures in very short right now. This is a maxillary sinus. I want to show you the drilling part. In any case of suspicious inverted papilloma or any benign sinonasal tumor or most likely an unknown nasal condition where you suspect it could be a tumor, you're supposed to do drilling on the site of attachment. So what I'm doing right now is just in the superior half of the maxillary sinus, the posterior wall, I'm trying to, just drill that mucosa and drill that bone as well, just in case if at all there is any suspicious bony attachment or infiltration. So just make sure you do not drill over the tooth area, and if you do so, the patient is going to have severe tooth pain for weeks to come. So be gentle about the anatomy. And what you can see, I can see the actual extreme limit of the anterior lateral aspect of the maxillary sinus. We see that this is only possible because of the Denkers we have done. That's the most lateral portion of the maxillary sinus having a head-on view. You can see the excellent vasculature of the mucosa as well. So in some time I'm going to show you the infraorbital nerve, which I'm going to show you right now. You can see a small bulge over there the ball probe is pointing at. Now that's the floor of the orbit. So the infraorbital nerve, it's a very important structure. Now this is some more drilling I'm going to do over there. So be sure the patient's tooth is right there. You don't want to be drilling on the patient's tooth. You got to be very careful. You can see that that's still the posterior wall of the maxilla, so which I'm drilling on right now. So I'm going to change over to my my 70-degree endoscope, and I'm going to try to show you the presence of the course of the infraorbital nerve right there. So that's the 70-degree endoscope facing downwards, and you can see the tooth right there. That's the inferior facing 70-degree endoscope. So if at all you want to have a good vision in the floor, you can use 70 in this way. Or you can just do a small pre-lacrimal approach as I showed you some time back without removing the medial or the lateral wall or anything. You can just do a pre-lacrimal approach with the flap intact and keep your 70-degree endoscope and just examine the entire sinus cavity inside. So I'm going to show you now the drilling part is done. So I'm going to show you the course of the infraorbital nerve right now. Okay, so I'm going to show you the infraorbital nerve course right now. That's the posterior wall, that's the roof of the orbit right now. The roof and the posterior wall junction. That's the roof where I'm pointing the ball probe right now. That's the roof. The bluish hue which you can see, that's the posterior wall of the maxilla. Now what I'm pointing at right now is the infraorbital nerve right there. That's the bulge of the infraorbital nerve coming on from the roof of the orbit, sorry, the roof of the maxillary sinus. That's the floor of the orbit. That's the infraorbital nerve right there. So I'm using my 70-degree endoscope facing somewhat downwards right now, and I'm trying to show you the most anterior lateral aspect of the sinus, which is very, very difficult to see in normal situations of FESS surgery. You can actually see a huge white color bulge on the wall, which I'll show you again with a pointer. So let me just focus and clear that area for you. So I'm going to show, you can see an actual bulge right there, the huge bulge. That's the infraorbital nerve in the center. And just next to it, you can see some reddish hue. That's the infraorbital artery running along with the infraorbital nerve. So you can actually see the infraorbital nerve. That's a huge white bulge. And just side to it is the artery. That's the nerve. That's my pointer pointing towards it. And just next to it medially, you can see a reddish hue. That's the vessel. That's the posterior wall of the maxilla. That's the roof up there. And the infraorbital nerve comes from the floor of the orbit. That's the roof of the maxilla, and travels anteriorly and comes out from the infraorbital canal or foramen. So I'm going to change my endoscope again, and So this is basically now the 0-degree endoscope I'm going to try to use. So as you can see right now, now this is a 0-degree endoscope, and that's the floor right now, which you can see with the 0 as well. Okay, so I showed you the course of the infraorbital nerve. Now I'm going to show you the anterior ethmoidal artery and the skull base. So that's the patient's sphenoid sinus. If you remember on the scan, we saw that this is a patient's sphenoid sinus on the right side. It's a very small sinus. If you remember, the scans showed that the left sphenoid was completely dominant and the right was very, very small. So here you can see this is a patient's right sphenoid and this is actually really, really small in size. So if you are a beginner or a newbie who's doing a FESS surgery, and if you open up this area, if you think that this is a very small sinus, and if you consider this as a posterior ethmoidal cell, you will end up damaging the pituitary or the carotid or the optic and cause a CSF leak as well. So you have to learn the scan in very detail and know your anatomy very clear. So that's the sphenoid sinus, a very small sphenoid sinus. That's the skull base above, and that's the anterior ethmoidal artery right there. That's the anterior ethmoidal artery which is being compressed by that mass which we removed. And that's the anterior ethmoidal artery right there for you guys. So I have exposed the entire anterior ethmoids, posterior ethmoids. I have exposed the skull base as well, and I've exposed the artery as well. So let me just decongest the area and show it to you much, much more clearly. So, as you saw on the scan, if you remember, the anterior ethmoidal artery, below the level of which was the entire collection of mucus secretions, the mass as well, and somewhat of contrast uptake was happening there. So I removed the anterior ethmoids, I completely cleared that off, and which we could see that the anterior ethmoidal artery is so compressed and thin flat because of the compression from the collection below. Just so let me just de suction it out, have a good wash. You can see all the structures very clearly. Whatever you see in white right now is all the skull base. If you break that, the brain will prolapse. That is the anterior ethmoidal artery right there in front of you, so thin and compressed. You can actually see a small area of laceration just because of the compression from the tumor. You can see there is absence of bony canal right there. There is no bony canal. You can see it's actually hanging in the mesentery right there. So that's the anterior ethmoidal artery. You can see the bony canal on the two extremes, that's the medial and the lateral, but in the center there is absence of the bony canal. That's the sphenoid sinus, that's the anterior ethmoidal artery, and above that is proper skull base. If you break that bone thinking that it's a sinus cell, you will eventually cause a CSF leak and a dural prolapse or the worst can happen is brain prolapse. So that's the anterior. Again, I'm going to keep on showing you the anterior ethmoidal artery because the tumor, the mass, the collection was compressing it superiorly. So you can see the amount of redness in the center. It's because there is no bony canal over it. It's completely necrosed because of the compression happening, and there is no bone. It's demineralized. Now I'm going to show you with a pointer right now. That's the skull base behind, and that's the anterior ethmoidal artery. I'm going to go close up and I'm going to try to focus it. So in such situations, you have to identify the anterior ethmoidal artery. So the anterior ethmoidal artery, it comes as a branch of the ophthalmic artery basically. So what you can see right now is the anterior ethmoidal artery without the bony canal in the center. It's a branch of the ophthalmic being a branch of the internal carotid artery. The anterior ethmoidal artery runs from lateral to medial in a lateral to medial direction at an angle superior to inferior. Okay, so I'm going to give a wash again. So I've exposed all the structures: sphenoid, posterior skull base, anterior skull base, the anterior ethmoidal artery, which you can see right now. I'm giving a wash directly on the artery. I've also exposed the patient's lamina papyracea, and I have done a thorough exposure of all the sinuses basically. Now what I'm left with is the frontal and the supraorbital, which I'm going to show you in some time. So I'm changing to my 70-degree endoscope to show you guys the frontal and the supraorbital openings. So this is a 70-degree endoscope going inside, turning onto your patient's right side, and there you can see two huge openings. This opening which you can see right now is the frontal sinus opening, and the one which is behind, which I'll show you in some time, is the supraorbital. So we saw the scan already. The patient was having a huge pneumatized frontal sinus, right? And also the patient was having a huge supraorbital cell. So I'm going to focus that again and go inside. So I'm asking my assistant to take a photograph of the frontal sinus glow from outside. So there you can see I'm trying to show it uh, on the outside part. Now I'm going to go inside and I'm going to focus my endoscope inside the frontal sinus. You can see two huge openings. The one which is anterior is definitely the frontal sinus, as we saw on the scans out there. That's the frontal sinus opening, a huge one. And exactly the one which is behind to that is the supraorbital. So I'm going to show you the supraorbital right now. So that is the one which is behind, right? That's the supraorbital, and the one anterior to it is the frontal. You can see a thick bone which is in between the two, and I do not really want to remove that because it is completely unnecessary. That's the frontal sinus opening right there, and that's the supraorbital cell opening with the supraorbital recess as well. So these two huge openings which we saw on the CT scan and we confirmed in the uh, intraoperatively. So you can see without any complications we have exposed, and that's the anterior ethmoidal artery right there. So as I showed you in the scan, it's a common rule, anatomical rule, that if there is presence of supraorbital cell, the anterior ethmoidal artery will be dehiscent. It will not have a bony canal. But in this case, as you can see, it is not having a bony canal, and also it is having a huge supraorbital cell with pneumatization. So that could be also the reason of the dehiscent anterior ethmoidal artery. But in this case, I'm more of the opinion that because of the compression from below, the infection, the compression of the mass lesion, the artery was compressed over a period of time. That's why it led to the demineralization of the canal. So these two openings, always remember, frontal in the anterior part and supraorbital in the posterior part. Okay, and exactly to the posterior part of the supraorbital cell, which you can see right now, is the anterior ethmoidal artery. Sometimes what happens that there's a thin bone which divides the two. You can just take away the bone and make a huge common opening. So if you have any queries, any doubts in this surgery, you can definitely message me. So I'm going to send this sample for histopath, and I'm going to update you real soon of as to what the report has come as. Okay.